Kia ora. I'm just going to oh yes, can everyone hear me all right? Yes? Oh good, I got a thumbs up. That's great. Louder? Is this on? Hello? 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 Yes, it's on. Right, I might have to nestle in like this and have it really close. Kia ora koutou, ko Sue Brewster taka wingoa. For those of you that don't know me, my name is Sue Brewster and I have the privilege of being the Executive Director for Auckland Medical Research Foundation. Thank you so much all for coming. We have heard that there's a bit of a traffic jam before the Harbour Bridge coming over this way, so I think people will still be coming in, so we've got still people stationed out there to welcome them, but we're going to have to kick off because of the live streaming. So I would like to welcome one of our esteemed board members who is going to do our formal opening for this evening, and could I please ask James Gray to come forward and do a formal opening for us. Thank you, James.
E ngā manuhiri, tēnā koutou. Nau mai, haere mai ki AMRF Lecture Series 2. Whakatau mai ki runga i a mātou. He mihi tēnei ki ngā kai tautoko o tēnei kaupapa ko AUT University, ko Auckland University, me JMI Wealth, kia ora koutou katoa. Ngā mihi nui ki ngā kai kōrero o te pō, Dr. Rosemary Frey, Associate Professor Cheung, me Professor John Windsor, nau mai. Ka huri atu te mihi ki a AMRF. Ngā kai whakahaere tēnei hui mō te rātou manaaki me te tautoko. Kei te mihi tuatahi te mātou nui, o te rangi nāna ngei mea kātua, tēnei te mihi kia koutou, ka nui te koa me te hari ki tūtaki i a koutou i te kaupapa. Nō reira, ngā mihi nui kia koutou, tēnā koutou, tēnā koutou, tēnā koutou katoa. For those who don't know me, yes, I'm a trustee on the Auckland Medical Research Foundation. My name is James Gray, and on behalf of AMRF staff and the board, I'd like to welcome you all here this evening for our second lecture of the series. I'd also like to thank some of our sponsors, AUT, Auckland University and JMI Wealth. Small caveat, I also work for JMI Wealth, but thank you for their support. We'd also like to welcome our speakers tonight, Dr. Rosemary Frey, Associate Professor Gary Cheung and Professor John Windsor. Welcome to our lecture tonight. Also like to thank AMRF, our staff, for putting this together tonight. Looking forward to hearing hearing the speakers tonight, and as you are all here in person and online as well. So yeah, I'd just like to welcome everyone here tonight, and I hope you enjoy this evening. Thank you.
Well, thank you, James, for such a wonderful wonderful welcome and introduction. And I'd also like to warmly welcome you all here tonight. Thank you for coming out on a chilly night, braving the traffic. At least it's a lovely, fine night, so I'm glad you could all find your way here. So, as I introduced myself before, Sue Brewster, Executive Director of Auckland Medical Research Foundation, and this is the second in our 70th anniversary celebration speaker series. So, and we're also here tonight celebrating the awarding over $100 million of medical research funding. So there's a lot to celebrate. Like James, I would like to thank our 70th anniversary partners, who are JMI Wealth, represented by James Gray here tonight. I'd also like to thank the Auckland University of Technology, represented here by Brett Cohen, and also the University of Auckland, and we have Mark here tonight representing as well in place of Frank Bloomfield. So thank you to your partners. You've made a lot possible to happen this year, and you are the ones also for AUT and for UOA doing the research, so that's fantastic. And obviously JMI Wealth are helping us bring in the dollars. So look, on to tonight's agenda. Actually, I must remember housekeeping. So bathrooms are out the front if you need, and also in the case of emergency, we can file out this door if that's easier, store up the exit, and we turn to our left and we go out the double glass doors and assemble on the grass area and then wait there for further instructions. Right, so on to the agenda for tonight. We have had the honour of funding Dr. Rosemary Frey, Associate Professor Gary Cheung and Professor John Windsor in the past, and we're very lucky to have them here tonight. So we're going to kick off the session very shortly with Dr. Rosemary Frey, then joined by Associate Professor Gary Cheung, and they'll do 20-minute presentations, and then we'll be able to have a small time for question and answers. Then we will kick in, we'll have a little stand up and a stretch, and then we'll kick in at approximately 8 o'clock to John Windsor's presentation, and similarly we'll have question and answers afterwards. So we hope to be wrapped up by 9 p.m. because that's pretty much my bedtime, and I'm sure it's all yours as well, so we will be wrapped up by 9 p.m. So now I'm going to introduce our first two speakers for the evening. So Dr. Rosemary Frey is a Senior Research Fellow in Nursing at the University of Auckland and has a PhD in Sociology and Social Psychology. Rosemary's research is focused on palliative care and more specifically end-of-life care. Rosemary has generated a significant body of evidence which challenges dominant paradigms informing end-of-life care practice and policy, particularly within the aged care residential sector. Her work and findings seek to empower teams delivering the service with the knowledge and confidence needed to deliver a quality palliative care experience. A lot, Rosemary, you do a lot, so... and I'll just introduce Associate Professor Gary Cheung as well. So Gary is an academic old age psychiatrist who has a joint appointment at the University of Auckland and Health New Zealand. He is a Fellow of Royal Australian and New Zealand College of Psychiatrists and is currently the Chair of the Subcommittee of Advanced Training in Psychiatry Old Age. He co-leads the research and implementation of cognitive stimulation therapy in New Zealand. In 2021, Gary was appointed by the Director General of Health as a member of the Ministry's Support and Consultation for End of Life in New Zealand Group, a statutory body for New Zealand's assisted dying service. Gary's presentation tonight will touch on aspects of his older adult health research and look at how his research is increasing the understanding of often complex factors influencing the person's journey of requesting and receiving assisted dying. So obviously with both topics, being palliative care and assisted dying, there can be some sensitive material in these presentations, so I just wanted to make you all aware of that, and hopefully you all came expecting these topics to be covered. So I think we're ready for Dr. Rosemary Frey to come and take the floor and talk to you all about palliative care. No, Rosemary will tell us exactly what she's going to talk about, not me. That'd be better, wouldn't it? Thank you. And you've got your lapel mic on.
Yes, I do. Tēnā koutou katoa, ko Washington te maunga, ko Charles te awa, ko Massachusetts te rohe, I tupu aka I hoi Boston, ke te kowhira ho no anaine, ko Rosemary Frey toku inwa. Can you hear?
Please bring the microphone closer.
Closer? Can you hear me? Can you hear me? Yes?
Yep.
We good now?
Speak up a tiny bit, Rosemary, if you can.
How about now? Can you hear me now?
You've got the lapel mic on, so you...
Yeah, can you hear me?
Yep.
Just make sure. How about now? Yay. Okay. I'm just going to cover a little bit of some of the work that I've been doing briefly. Who I am, my research projects for the past 10 years have tended to focus on palliative care and end of life, particularly for underserved groups, including older people. That's been my work. These are some of the recent grants that I've been involved with, the AMRF Experiences of the End of Life Choices Act that Dr. Gary Cheung will talk to you about in more detail. And the other two projects on which to touch on deal with hospice care delivery after COVID. So what kind of innovations were developed during lockdowns that actually have uses now? And the second project I want to talk about a little bit is looking at telehealth for underserved populations. How can we reach more people with telehealth? Those are the two projects that I'm going to talk briefly about. So the first project, hospice care delivery for patients with life-limiting illness post-COVID-19, I conducted with Dr. Tess Mawiki-Maxwell, Ms. Jenny Thurston, Jackie Robinson, Dr. Deborah Raphael, Dr. Lisa Williams, and Professor Marion Gott. All except Ms. Jenny Thurston are from the School of Nursing. Jenny Thurston is from Mercy Hospice. Okay, everybody knows what happened during lockdown. Services were crawled back. People couldn't have access to things. But that's only half of the story. What people had to develop new and innovative ways of delivering healthcare. And so that's what I wanted to explore. What innovations did people come up with to help serve the community that in a way that was new? So that was the aim of the project. It was a two-phase project. We used transdisciplinary action research and a partnership approach. So it's working with people rather than looking at people as subjects was the idea. In part one, we used a telephone survey, which was either telephone, video, or in-person survey. And we sampled areas where during COVID there was a high incidence of COVID. So more than 25 cases per 100,000 was where we were looking at locations to talk to healthcare providers. We looked at hospices, we looked at community groups, hospitals, organizations that worked with hospice. The idea was to get a picture of what they all did during COVID. That was phase one. And in phase two, we recalled some of the participants from the first part of the study and asked them to talk specifically about their innovations. What things did they develop? How well did they work? Are they still using them? We had two different, what we called Think Aloud sessions. The first one was stakeholders from the various reference groups. And the second one focused specifically on Maori needs, palliative care needs, and Maori health professionals, which those sessions were guided by Dr. Tess Mawiki-Maxwell. So we used a short questionnaire because people are time sensitive and they don't have much time, and we had open-ended questions. We used both inductive and deductive analysis, guided by the questions we asked. Phase two is also a thematic analysis. And in that phase, we categorized the recommendations that people came up with. So these were the themes from phase one. The three broad categories dealt with competence, relationships, and then indigenous activation. There was a lot, I'll go through them briefly, the sub-themes. So, telehealth existed before COVID. It's just that people didn't want to use telehealth before COVID. They didn't have to, so they weren't going to. But what people found was once they actually got into using it, that it actually was a useful service to have. And so they've continued on with it. And what they've found as well is that not only did they feel more comfortable with it, but it actually met some patient needs. Having to come in to visit a health professional was not always easy to do. So having the option of telehealth was better for some people, and that they didn't realize it before. Policies, there was a lot of information around policies, particularly visitor policies. There were lots of rigid restrictions when COVID first hit, and what the hospices and aged care facilities found was that rigid enforcement of those policies led to lots of problems in terms of grief that hadn't been dealt with. And so what they realized is that they had to change how they did their policies. I have a quote from one of the hospital physicians as to their way of looking forward. We can stop the disease getting in, but we don't want to lose our compassion. So it started to be a more flexible way of looking at how you do policy to meet people's needs. Education in terms of COVID lockdown, particularly in aged care, they found there was a lot of gaps in terms of what nurses on the floor, what their knowledge was, and they found they needed to address it. But it has led to a lot of upskilling in terms of what people are now able to do. Community. New relationships got formed, or relationships were there but were strengthened. There were other situations where people, there was damage to some relationships because hospice, for example, decided to close their doors and they weren't going out and doing community visits. And so it fell on the district nurses. So there's a building of fences that's still going on right now. Lockdown also had an impact on team cohesion. Prior to COVID, people just were sort of siloed and did their jobs. During COVID, this one particular example, they talked about how they had Zoom huddles to see how everyone was getting on. And they continued these huddles after COVID, not in a virtual way, but they checked in with each other, and it strengthened the relationship in the organization. In terms of Indigenous activation, the first comment has to deal with the fact that there was a barrier that Maori health professionals found in terms of dealing with the community. Having the mask and the PPE created a barrier in terms of establishing a relationship. So what they had to do was they would stand at the door, show her who they were before going in so that they could connect with the person, which was really important. The second factor that happened was that care wasn't just limited to health provision. It was wraparound care. It was a holistic idea of how you provide care to your community. And that sort of has continued as well. And the third factor that arose out of COVID was that caregivers at home realized that they could do things. There was a sense of empowerment in their own abilities to deal with taking care of a loved one that they didn't have before, as the quote is showing. Okay, phase 2, I just talked about some of the tools that we developed. DocSeeMe is actually pronounced DocSeeMe, and it's basically a telehealth tool. Has a lot of wonderful features. It was developed in the US, and it's a secure platform from which to have visits, GP visits. This was provided by a GP. New policies got developed, linkages between, in this case, a hospital and the what was DHB at the time, such as a repatriation policy. Interestingly, there was new thinking in terms of a GP practice, where during COVID they had a red zone, and the GP talked about how there actually should have been this sort of arrangement in the first place, because I have older clients who have various health issues, maybe some of them are immunosuppressed. I should have a separation. I shouldn't have everybody in the same waiting room. So that has been continued as well. The final comment here has to do with communication. They realized that too many people were contacting people at home, and there needed to be a streamlining from on the multidisciplinary team as to who is contacting the caregiver at home, so there's not an assault of information going to the person at home. Okay, so the recommendations basically have to do with keeping going with exploring digital health, being flexible with visitor policies, continuing exploring more relationships, interdisciplinary relationships, keeping up the team cohesion, and one of the key things was more embedding of palliative care within the aged care sector. It's in some places, but not all. For Indigenous activation, more connection with the families. What was spoken about was the fact that while there are resources on a hospice website, they're all over the place. It needs to be collated in one place so that it's easily accessible. Access to the well-being of there has to be more connection to the family at home as well. More collaboration, particularly with Maori communities. They felt that everyone was sort of doing their own thing, and there needs to be a more general plan that gets everybody in the loop. And they came up with the idea of that maybe there should be like a civil defense plan that included hospice as well. So that was my general conclusion from that project, not to forget the things that were so hardly learned. My second project, briefly speaking about, has to do with underserved communities. This is a Catalyst Fund grant. I'm collaborating with Associate Professor Aileen Collier at the University of Flinders and Matthew Alsop, Dr. Matthew Alsop from the University of Leeds, and Dr. Sarah Mitchell, who is the National Clinical Director for the NHS. The goal of this is to basically see what's out there, what telehealth services exist, and is there a way that we could adapt any of them to here that would be useful for underserved communities here. So year one, so last year in 2024, we went to visit 6 organizations in the UK. This coming year in September, we're going to be doing site visits in Adelaide, Australia, bringing together Australian elders, and they have a reference group, and Kaumatua from the Rawaawa Community Trust here, and bringing them together in Adelaide to discuss access issues for telehealth for both of those groups. So there were 6 organizations that we visited. I have a list of them somewhere. I won't go into it. Basically a telehealth hub. We went to 2 hospices and looked at what they're doing in terms of telehealth services. One of them is a teaching hospice, one of the few teaching hospices in the world that not only does the services but also does research. And we went to a national patient advocacy group called Compassion for Dying and support organization. I'm not going to go through all of these. These are just some of the projects that they had going on, just some of them. ECHO is basically for physicians and health professionals. It's a knowledge sharing service. Originally developed, I think, in the US. Breeze is a patient service for people with chronic respiratory conditions. It's a series of videos. It gives them coping strategies. I talked about Compassion for Dying. It supports individuals in terms of information. They do legal services in terms of filling out documents. They do advocacy as well for underserved communities. They particularly work with ethnic and minority communities, getting them information about end-of-life materials. Gold Line is a 24/7 telehealth service developed in Leeds. It's one of a suite of programs. They have one for aged care. They have one for just people with chronic conditions as well. They have a service for prisons as well. So this is one of the services. We heard a presentation by Dr. Mitchell on, they have a data set that looks at major conditions and hospitalizations, place of death and demographic characteristics. What it showed that 50%, fewer than 50% of the people who die are on any kind of end-of-life register, which I found fairly interesting. Again, more services that have to do telehealth services. Marymount Hospice, and I'll talk about in a little bit more detail. Compal is an AI-driven service for people with dementia, which is an interesting service. I'll talk a little bit about Gold Line. The 24/7 service is headed by Dr. Linda Wilson. Gold Line was launched in 2013 in Leeds and Bradford. To be eligible for it, you have to be registered with a GP, and you have to meet the criteria, the prognostic criteria for the gold standards framework. What's good about it is it gives you connection to patient records and ensuring they're up to date. It's integrated with the local health network, which is really good, and it provides resources for patients. Challenges still in terms of there are some areas where it does not reach. Underserved communities still do not have access. Funding is an issue. They have, at the moment, they have a public-private partnership going on. So there are different goals depending on, that is a problem. It's the only scheme around in the UK at the moment, so there's no way to compare it with other services to see how well they're actually doing. Marymount Hospice is one of the hospices we visited. These are Aileen is second to on the left there, followed by Matthew, and I'm way down there on the end there. These are just some of the services that they offer. They offer virtual consultations, symptom management, psychosocial support. They even have telehealth. Physio is included as one of their services. One of the problems they have is that it doesn't reach everywhere. The area that they covered includes islands off the coast, and the telehealth does not reach there. So there are in-person visits that have to be done. And in fact, they do in-person visits with everyone before they sign up for the telehealth. Those who can reach it still have to have an in-person visit first before they follow up. Okay, so the telehealth applications are great. Yep. The models like Gold Line have a lot of potential, but there's still practical issues in terms of how you include everyone. There's still people who aren't being reached. As I said, there's trouble between the public-private partnership. They have different agendas, right? It's great that there's increasing research attention on understanding engagement with telehealth systems. There's lots more research than there used to be. There's research into patient safety in low resource settings that's just starting to grow. And a focus on engagement in low resource settings, which is just starting to pick up now. So where we go from here. So the next stage, we're going, as I said, we're going over to Adelaide to do the consultations between the Kaumātua and the elders. And that will be followed up in the year after with a hui in Hamilton at Rawaawa Community Trust. more exchange of ideas. The ultimate goal is to come up with some kind of proposal as to a test intervention telehealth service that we can apply for funding for. So that's our goal. Before I leave, I just wanted to thank all my colleagues who have been involved in all the research that I've done, Gary as well, Professor Marangott and the TRI Palliative Care Research Group, my head of school, Dr. Julius Lark, and all the people who've kindly given their time to be a part of the research. I wouldn't be anywhere without them. Thank you so much.
I'm just thinking while we've got Rosemary up here, we might do, because it's fresh in everyone's mind, we might just do a few questions now.
Oh, okay.
Yeah, rather than go straight into Gary. So one of our runners is running.
Oh, run.
Any questions? Can I get you? Yeah.
Don't be shy. I can bring the microphone to you. Is it on? I've got a question, Rosemary.
Okay.
What is your biggest concern for palliative care in New Zealand at the moment?
Only one.
Only one. How many concerns do you have?
Access issues for underserved communities is one of my biggest ones at the moment. Yeah, getting palliative care incorporated into more aged care facilities. It's in some, particularly in Auckland, but not everywhere. That's another one of my concerns as well. I think those are the two top ones. Yeah, just having people have access, and just information is lacking, I think.
And so your research aims to, I guess, provide services and things that are going to help with that access.
Well, at least find ways to help clinicians be able to get the information out to people. Yeah, if I can't do it directly, do it through them, so they have the information to be able to deliver it. Yeah.
Any other questions while we've got the mics? You might think of something, will be prompted to by... So, oh, Jeff's got a question.
Thank you. I'm just interested in any thoughts you might have about integrating AI, artificial intelligence, with the research work you're doing, and the effectiveness of AI in on-the-ground work.
Well, as one of the projects, actually a couple of the projects up there are integrating AI, and I'd like to see what the outcomes of those research projects are to see how well it could be adapted to here. There are a couple of big projects. I think that the European Union is funding one of them. I'd like to see what their outcomes are, to see how applicable it would be to here.
Thank you very much, Rosemary. Yep, wonderful. Yep.
Okay.
There's a lot going on there with your research, that's for sure. Yeah. So now I'd like to invite Associate Professor Gary Cheung to take the stage and talk to us about his research. And you're mic'd up, so you're good
I'm ready to go. I might stand over there. This is a big stage, isn't it? Kia ora koutou, ko Gary Cheung tuko ingoa. This is a very serious topic. So in the next 20 minutes or so, I'm going to summarize our research on the use of assisted dying in New Zealand. So assisted dying been legalized in New Zealand for the last 3.5 years. It was the 7th of November 2021 when it was implemented. I remember that day because that was my brother's birthday, 7th of November. And this is a serious topic, but because AMRF has funded our study, so I'm here to talk about our study. Just a little bit about myself. I'm an old age psychiatrist, so I specialize in the mental health of older people. I have my week is very interesting. Mondays and Tuesdays are my clinical days, so I see older people with mental health issues and dementia in an outpatient setting. Wednesday, Thursday are my teaching days and some postgraduate supervision, and Friday usually my research day. But I'm taking an annual leave tomorrow for good reason. I'll tell you later. So that's my teaching research. Assisted dying actually is a very small part of my research. A lot of my research is with dementia and particular psychosocial aspects of dementia, how to improve the quality of life of people with dementia. And service to community. I'm a Chinese, born in Hong Kong, came here as a teenager, and we know dementia services for the Chinese community is really lacking. So some of my time is giving back to my community to improve information resources for Chinese with dementia. So I think, Sue, you mentioned I was a SKINS member, so I need to declare that for the first 2 years of the legalization of assisted dying. I'm a rare breed, actually. I'm a late-life suicide prevention researcher, but also an assisted dying researcher. So not many of us actually in New Zealand are doing both research. It was about a decade ago, I was doing my doctoral thesis that was on suicide prevention in older people. And part of my research was reading coroner's report of older people who died by suicide. I read many suicide notes, and some of them, actually 10% of older adults completed suicide had a terminal illness. So 10%. And when I read their suicide notes, I was in tears. Yes, I'm a psychiatrist. I usually can hold my emotion. But the suicide note talk about the suffering they have, the lack of functioning, lack of independence, and they choose to take their own life. For me, it's a very strong message. I have to declare I am neutral in terms of, well, maybe a little bit over neutral in terms of supporting assisted dying. I see that as an option for people. Not everyone's option. For some people, they may want that as an option. So that's how I got involved in the assisted dying research. It's actually from my suicide prevention research. I don't do a great deal of suicide prevention research now. Having said that, I just have a project with my colleagues in Australia looking at adapting their education tool for gatekeeper, looking after older people so they can recognize the sign of older people at risk of suicide. So there's the funding from the Office for Seniors, so we will complete that in the next few months. So this was 2020. Did you vote at the referendum? Some of you. Anyway, 66% of New Zealanders voted yes for assisted dying, the End of Life Choice Act 2019. And this is the eligibility criteria. So I'll go through this with you. So to be eligible for applying for assisted dying, you have to be over 18. You have to be a New Zealand citizen or permanent resident. Suffer from a terminal illness that is likely to end your life in 6 months. Now, how good are we in prognosis? So some of the research are telling us why 6 months. Certainly in some states in Australia, they are 12 months. In Canada, they are 12 months. And in fact, in Canada, there's no limit in terms of the life expectancy. So the person also needs to be in an advanced state in irreversible decline in their physical capability. Unbearable suffering. How do we measure suffering? It's a complex construct, actually. I said I'm suffering. Who's going to argue with me? So, of course, there's physical suffering, but it's also psychological suffering, existential suffering. In fact, when you look at the literature from Canada, existential suffering is one of the top ones in terms of the reason people wanting assisted dying there. Well, the last eligibility criteria is the most important. The person has to be competent or has capacity at the time of requesting assisted dying, also at the time of medication administration. And as a psychiatrist looking after older people, that is my specialty, capacity assessment. So that sort of brings some of my interest in this area as well. Because we know it's difficult to assess capacity in general. And doctors have told us that a lot of time, and that's been confirmed in research. Capacity often have poor inter-rater reliability. So I may say this person is competent or has capacity, and that doctor come to assess the person may say the otherwise. And the literature has been telling us the inter-rater reliability is not that good. And this is a serious issue, isn't it? Assisted dying. These are the latest figures from the last 2 years. These are the numbers of people who apply to have assisted dying. What can you see here? It's going up, isn't it? As more and more people requesting assisted dying. And so in the last financial years, over 800 people applied. Not everyone ended up having assisted dying. Majority was Pākehā, very small percent, 4%, so Māori, just under half a female. Majority was 65 years of older, so that's my work, older people. About 3/4 receiving palliative care at the time of the application, and not surprising, about 70% have a diagnosis of cancer. So these numbers, these figures are fairly similar compared to other international jurisdictions. Okay, I'll go back to here. Do anyone know how many deaths per year? Well, Rose probably know. How many deaths in a year in New Zealand? More than 20,000. More than 20,000. So it's between 37 to 38,000. Actually, I asked ChatGPT on the way here. Someone talked about AI, but I remember reading. I can't remember. It's a 30 something, but then I checked. It's 37 to 38. About 1% of people who died in New Zealand had assisted dying. So the number, if you do the maths, it's about 370 cases of assisted dying per year at the moment. So just 1%. Canada, they have assisted dying longer than us. Do you think it's higher or lower? Higher, 4%. It's cold. It's cold, yes. Very cold, yes. I've never been there in winter. I like the summer, but never been there in winter. Victoria, Australia. Are you higher, do you think? It's actually a little bit, they're just under 1%. I don't know.
It's warmer.
No, not in Melbourne. That's colder than us. Now, one of the things I learned from our Australian colleagues is in New Zealand, assisted dying is free. It's a free service provided by Te Whatu Ora. In Australia, people have to pay their GP to have that. I actually don't know the funding that well, but I know they have to. Some people have to pay to request and then have the assessment. I don't know that's the reason, but as I was driving here, I thought, well, that could be a reason. You may think of other reasons as well, like the temperature. So, okay. So this is our research. That's the research team. So because such a serious topic, I got a lot of my psychiatrist colleagues to be part of the team. So the team was formed between School of Medicine, Psychological Medicine, and School of Nursing. Rosemary lead the School of Nursing team. I highlighted Ida. Ida's actually in the audience. I didn't highlight your name because you were coming. I was doing that anyway. But Ida emailed me. I put in my slide, I think Monday afternoon, wasn't it? I think Ida, you emailed me later. And The reason is Ida finished her PhD with Philippa Malpas, ethicist in our department. Just before we got the grant, like about 6 months or so, and Ida's PhD was how to safeguard assisted dying in people living with dementia. So when we got the grant, you were one of the first persons we found. Ida, would you like to work with us? So Ida spent 2 years with us as a research fellow conducting this study. So Rosemary and I are very grateful because without you, we couldn't have completed this study. We can have the funding, but we wouldn't have the people to complete it. So thank you. So it's a 2-year study. The first year, we look at the Ministry of Health Workforce Surveys. So prior to the implementation of the Assisted Dying Act, the ministry have done some workforce survey. They did 2 cycles of it. And we analysed that. Well, I'm not going to talk too much about that because it's all numbers. Numbers can be a little bit boring this time of the day. But in the first year, we interview, when I say we, not me, Ida did, interview practitioners who were involved in assessing people for assisted dying. And these practitioners have no experience prior to that point. Having said that, there may be some, I think at least one person have done assisted dying in Canada and returned to New Zealand to work as a GP, and some of his work involved assessment for assisted dying. So that was the first year, and then the second year, interview partner and families. So that was a 2-year grant. So this is the, so Ida interviewed quite a lot of people, 22 practitioners directly involved with providing assisted dying assessment and service as well. Also talked to a group of practitioners who were not directly involved, like palliative care specialists, but they may have patients that have gone through that process, because we want to hear their perspectives as well. And later on, about a year later, I have a registrar. I was teaching this topic, and he was very interested in how assisted dying practitioners go about assessing depression in people requesting assisted dying. So Eric, I said, oh, yep, if you want to, we can add you into the project. So he also interviewed separately 10 people, and I'll show you some of the results of his result, which is quite important. And we're going to talk to the Ministry of Health, sorry, Te Whatu Ora, next in a couple of weeks about the result as well. So you're one of the first people to hear it. And we also talked to whānau family, Maori and non-Maori. For non-Maori, Ida did the interview. Maori, we're very lucky. We have Dr. Tess Moki-Maxwell, also involved with Rosemary's other research, did the interview for Maori as well. So these are some of the issues that came up when Ida talked to practitioners involved in delivering these services. There's the conscientious objection. So as a health professional, I can declare conscientious objection. So I don't need to be involved, but I need to declare that upfront. And if a person comes to me and requesting assisted dying, and I'm a conscientious objector, I need to direct the person to seek help elsewhere. I can't just ignore that person. But that actually happened a bit in reality. Some practitioners didn't want to know and didn't direct the people to other resources. Prohibition to raise assisted dying. So as a health practitioner, we are not allowed to raise assisted dying with the persons. Even the person have a terminal illness, I can't say, would you consider having assisted dying? Can't do that, but no, I'll be in trouble. I'll be behind bar probably. We can't raise it. And that is an issue, because if you don't raise it, people don't know about this as an option. And that comes out a lot when we interview the family, that how to go about finding information. Having said that, the ministry and Te Whatu Ora have really good resources on the internet, but not everyone goes to the internet. So finding out the information, certainly overseas, certainly in Australia, some states, practitioner can raise the topic of assisted dying with the person as an option. And I guess some people may want to know all the options, don't they? Yes, we have palliative care. Yes, that's an option. At the moment, we can't raise assisted dying as an option. We are too frightened even to put pamphlets in the office. So that's a bit of a grey area there. Eligibility criteria, I showed you the eligibility criteria before, and I've already mentioned, how do you measure suffering? There's no blood test for suffering. It's all come down to your examination and history. The prognosis of 6 months, how good are we in determining that? Setting a date can be difficult, so the person has to set a date, and sometimes the person died before the day of their chosen day. And the practitioner told us administering medication is quite, sometimes can be quite tricky, because people with terminal illness, they don't have very good veins, and you need IV access for that. So these are some of the issues that came up in our research. We've written up the research. Yes, it's accepted for publication, isn't it? Yep. So at some stage we can share that with AMRF. If you're interested, you can have a read of the full report of that. And that's a really good resource, actually. If I'm a new practitioner, I've never done assisted dying before, I would go to read that report because it's telling me everything, all the details, what happens. We have a lot of quotes from the practitioner. I'm not going to show you this one. We also talk to people who are not directly involved, the practitioner. So these are like palliative care, physicians and GPs, but their patients chosen to have assisted dying. They're telling us that we need better interface between palliative care and assisted dying services. At the moment, there are 2 separate services. There's no overlap. And people are telling us, oh, we need, palliative care specialists say, we need to learn something about assisted dying. And they're also saying, oh, assisted dying practitioners need to learn something about palliative care. So there's a lot of cross-pollination, and we need to do a bit more of this. And that flow on to the education that's between those 2 specialties. This is quite important finding. So my registrar, Eric, talked to 10 practitioners and asked them, how do you go about assessing depression? Because we know, well, as a suicide researcher, we know people wanting to die have high rates of depression. And the literature have told us that people requesting assisted dying, a high proportion of them actually have depression. So assessing depression is actually quite important. Now, how do we treat depression in the terminal ill is a different topic because there are limited treatment and also the life expectancy and so on. But if someone requesting assisted dying and have depression, that can skew their view of the world. So Eric asked them, how do you go about? And the practitioner told us, well, it's a minor concern really, it's not that important. That's what they're telling us. They don't have a formal approach to assess depression. As a psychiatrist, our approach of assessing depression is very structured and methodical. These are the symptoms we need to check. If you score so many of these symptoms, we can make a diagnosis of depression. But the practitioner is saying it's very informal. They don't follow that structure. The third point, they say yes, and we agree with that. There's a lot of overlap between depression and people with the terminal illness. Of course, people with a terminal illness, they're not going to jump for joy. But actually, it's quite difficult as a psychiatrist to differentiate between is it depression in terminal illness or just terminal illness. I sometimes find it difficult myself. And so that is an issue. How do you assess that? The last thing they told us is we don't want any structural process. We're quite happy what we're doing. We don't need any screening tools or anything like that. It's not an important issue. So for me as a psychiatrist, I don't like hearing this. because this is a serious assessment. We want to make sure the person doesn't have depression, because depression can also skew with that person's capacity. So when I talk about capacity as a safeguard. So we're going to take these results to Te Ora, the assisted dying service, in a couple of weeks and see how we can work together to improve the situation. So this is important research because they have direct clinical implication. I know the 10 people told us we don't want to change our process, but we may have to. I mean, do you want a change in process? Okay, lastly, these are about interviewing families. So this happened in the second year, and Ida talked to 15 families, members. 7 of them did not, that their family member who died didn't use assisted dying. Some did, some considered, but ultimately didn't, so there were 6 of them. And then 2 actually used assisted dying. I'm not going to show you all the results, but I think just read the top, secrecy about assisted dying. People don't want to talk about it. I guess we're not very good at talking about death anyway, in general. But if it's assisted dying, and if I have a family member died by assisted dying, I don't want to tell other people. And then the family holding all this information themselves and not able to process the grief. Because part of grief is to express the grief and communicate that with your friends and family. So if you hold that as a secret and not able to process that, family get affected as well. So Ida's the next project, well, current project is looking at support group, how to support family, their loved one have died through assisted dying. Not just family, but another support group for practitioner that have gone through. Because I haven't told you, practitioner also say it's quite an emotionally charging experience for them. Because doctors, we're not taught how to take, we're pro-life, we're not taught how to end someone's life. So there's emotional issues there. So yeah, Ida's doing that. She has an HRC activation grant to run these groups. So you're going to be quite busy. Okay, I'm probably over time. So I'm going to talk about this. I'm going to the final slide. How about that? Okay, conclusion. I didn't talk about the last point, so ignore that. So still relatively new, end-of-life care in New Zealand, 3.5 years. And the experience of the health professional will continue to evolve. So it may be worth doing another study in 5 years' time, I don't know, to see what happens then. Are they going to tell us the same story? Maybe, maybe not. Do we ask that? Do we need a more standardized way to assess depression? And yeah, a need to support both family and health professional. And I also mentioned we need to monitor the suicide statistics. We just don't know. It's an area we don't know. Whether assisted dying can reduce suicide rate, we don't know. International literature say it's equivocal, we're not sure. So an area we need to watch for. So thank you.
Right, well, we've got Gary up here. We've got 5 minutes for any questions. Yeah, and it's a difficult topic, isn't it, Gary? Yeah. So thank you for expressing it in the way you have. And
Do you want a mic here?
Yep, Mike. Here we go. Here you go, Joy.
Are you aware of any figures showing a difference between assisted dying in isolated or more rural communities as compared with city communities, please?
Yes, I would say no, I'm not aware of any figures at the moment. I haven't looked into that. Yeah. That's a good research question for us to go away and have a look at that. The data is there.
I do recall in the news media a commentary on that, but I just can't remember.
Yeah. Do they think it may be higher in rural areas?
access
Okay,
again, yeah.
good point. S, yeah,
There was a woman on a doctor
yeah.
on radio. She's her own airplane and she flies all over the South Island
Ah,
to provide access.
oh yeah, would you like?
Sorry, the live stream won't be able to hear your comments.
Yeah.
I don't know the name of the doctor, but she's, in fact, she's quite senior in Doctors Association and stuff. But she drives, she flies her airplane across parts of rural New Zealand to
Right.
provide access because she
Okay.
believes so strongly that people need access. So it's quite a challenge.
Yeah, and we'll,
Can I just say, I worked previously at Waitamatta and I used to assist we're very few numbers that the hospital was asked to assist with. And I think it's interesting to have the observation, and I will just speak to because as chief nurse, I decided that my nurses felt really conflicted about participating. But actually, my observation, and when I worked alongside the nurses in supporting the doctor who was often called to do it, it was the most beautiful experience for the family and to the client. They were really clear what they wanted, and it was done with beauty.
Yes.
I've never seen a more peaceful ending. And I probably would say there's about 8 times that I participated to support. I was only just there as a nurse to support.
Yes.
And it was done, what did find a challenge was the funeral directors.
Yeah.
No one had spoken to them about this, and so they were conflicted, but there was no support for them. So I think there's definitely a need for the support processes. And I know that I offered support to the doctors sometimes too, who sometimes felt just because there's such a small number of them and they have to fly all over New Zealand. Yes. Yeah, I think the people that I experienced, they had the long-term conditions, you know, and they were really reaching end of life, and they didn't want to be a burden. I think that was all. But the family were very upset, but still very supported.
Yes, yes. Thank you, thank you. The rural access is an issue. So under the Act, you need 2 practitioners to assess the person. If either of them have issues or questions about the person's capacity, they can refer to a psychiatrist. So I'm the psychiatrist list, but I've never seen a person because often they need someone to assess tomorrow. And I can't cancel my own clinic, and they live in rural areas, so rural access is an issue. Because of limited time, I didn't tell you all the other stories the practitioners have told us. I have heard a lot of stories about the satisfaction the practitioner got out of helping the person a peaceful death. So that go with what you've observed. Thank you.
Just one very quick question from me. So when you put up the slide that said 834 applications, but then only 370,
Roughly,
So is that because a lot of the applications weren't eligible?
Yeah, and some people also died before the days they set for assisted dying. Or they changed their mind, maybe.
Can I just ask in relation to that, what is the average length of time from an application? What's the average length of the time from an application to actually having assisted dying? Is this a week usually, or is it
Ooh, 3 weeks? Thank you, Ida.
On the website, it says it should take around 6 weeks, but we've seen variation from it can be expedited if there is a sudden decline in health and the death is impending and they've been approved, so they can bring the date forward if that's the case. But we've seen like from week 10 days up to a couple of weeks, so it varies depending on the situation and and resources and everything.
Yes, the person, we came across a person in our service and took him about three weeks. So it's variable,
Right, well, I think we better close it there. And thank you very much, Gary. That was really informative, and thank you for handling such a sensitive subject as well. So, a little round of applause for Gary. Thanks. Okay, we will have just a 2-minute break, so you can have a little stretch or a chat to your neighbours, and then I'm going to ask Dr. Tim Angeli-Gordon to introduce Professor John Windsor.
go through the process of seeing two doctors and then refused. Well, like for my GP in a rural area, it takes some, to get an appointment in tomorrow, to get an appointment with my GP, it would be more than 3 weeks. Like you cannot get an appointment with a GP without seeing a nurse practitioner, and that will be nearly 3 weeks. That's, in fact, the last one was, I think, exactly 3 weeks to see the nurse practitioner, and the doctor wasn't really questioning, saying, but actually, I don't know, it's exceptional, perhaps circumstances for sure. So maybe normally, maybe it's a good doctor in about 3 weeks. 3 weeks where you can see the first doctor that you see them, although there is no other doctor in the area. There's only one doctor in the area.
Waiting for. Yeah.
That was interesting, saying that living in a rural area, Martinborough, it takes 3 weeks to see, you can't even see the doctor in 3 weeks.
Wow.
3 weeks to see a nurse practitioner, you phone up, and it takes 3 weeks unless it's urgent, and they have a certain number of appointments each day.
Isn't that crazy? Absolutely crazy. All right, I think we're going to...
So I think
I think we're going to kick off just because of the time and
Kia ora koutou anō. Welcome back after a brief stretching break. I am not Professor John Windsor. I am Tim Angeli Gordon, but it is my distinct honor tonight to get to introduce Professor Windsor. He didn't know I was introducing him, and he asked me to be kind. He also asked me if I had his bio, which, full disclosure, I have made up this bio. So, but one of the things I love about these sort of nights is getting to meet the people as well and getting a bit of an insight into who they are, not only their research, but also who they are. And I think we had a wonderful window into those first two speakers. So I will try and also give us a bit of a window to Professor John Windsor. One of the things as academics, we hear people's degrees or titles, and we joke that those are letters after your name. So as you get a degree, you typically acknowledge that by putting the letters after someone's name, and it tells qualifications of people. I realized there were too many to read, but I also thought to myself, I said, I wonder if there's more letters after Professor Windsor's name than are in the alphabet. So are there more than 26? He asked me to be kind, so I won't belabor the point, but there are 34, and those are just the ones I've found, so there's probably a lot more than that. And I don't say that to put him on a pedestal necessarily, although he deserves it. But because that tells me a few things about who he is. One, he loves learning. Two, he's always striving for excellence. And three, he's widely respected by his peers. And I think all of those are really admirable traits. So most of his peers and others would describe him as an academic surgeon. So that captures a couple of different facets. One is a surgeon, and he's a phenomenal surgeon. And the best way I can capture that is that in talking to his surgical colleagues, many, many, many of them have said that if they ever need to have surgery, they want Professor Windsor holding the knife. And I think that is the best compliment that you can have. Now, academically, he is also a prolific researcher. He's published well over 400 papers in some of the very, very top journals in the world. They've attracted over 30,000 citations. So a citation is when somebody else publishes a paper and refers to his work. Over 30,000 of those. But imagine, if you will, for a second, the number of people that have had conversations in the laboratory or around the clinical ward or around the surgical theater that have referred to Professor Windsor's work in their clinical practice or in their clinical care. I would dare say it's many, many higher than that 30,000, which is already a phenomenal metric. As if that's not enough, being both a surgeon and an academic, He's also a great innovator and an entrepreneur, which I think he'll touch on tonight. But you can look up all of that information on Google, which is part of how I created my own little bio for him here. But what you can't look up is, I think, what to me sets him apart, and that is his mentorship. He's a phenomenal mentor, and there's literally an entire generation of surgeons internationally who have been trained by Professor Windsor, as well as an entire generation of academic researchers. And I'm happy to put my hand up as one of those people who has benefited from his training as a researcher. We haven't spent a ton of time together, but in the time we have spent, he's clearly one of the most influential mentors. And the best way I can describe that and who he is as a person is every time we meet, I realized when coming up with this little bio that he asks me three things. He asks how I'm doing, he asks how my whānau is doing, and he asks how he can help me. And I think if we just think about that last one, every time we catch up, he asks how he can help me. That really, I think, sets him apart. It's something that we need a lot more of in academia, I will say, and something that is the highest compliment that I can give to who he is as a person. So I'd like now to welcome Professor Windsor to the stage.
I don't know what to say after that. Thank you, Tim. Can you hear me all right? I'm going to wander a little bit as well. Really kind words. Thank you, Tim. It's easy to mentor somebody like you. I want to spend a few minutes with some introductory comments, and then I want to go through 3 clinical observations, a new paradigm, 5 laboratory experiments quickly, not too scientifically, I hope, and then 2 translational treatment strategies which we're working on that comes out of this new paradigm. You'll have seen that talking about a forgotten highway and organ failure, I hope it will become apparent what the highway is. Should be obvious. Firstly, I want to thank Sue and her whole team, the trustees, those who review grant applications for their support. 2 recent projects which have been supported by AMRF, which I'm perfectly involved in. I supervise Sang Ho at the top there, part of Kaitia Health, where they're doing intracranial monitoring of pressure for hydrocephalus, going really well. And then guess who? Tim, doing some great work on endoscopic mapping of gastric arrhythmias, or gastric electrophysiology, and also looking at ways in which we might treat abnormalities of rhythm within the stomach. Exciting work. Now, my favorite topic, the pancreas. Pancreas often forgotten. In fact, early anatomists said this is just a fat pad upon which the stomach sits. Actually, it's a highly complex organ, and most surgeons don't want to touch it because it bites. There's 2 organs in one. It produces enzymes for digestion. It produces hormones for metabolic control. We don't really understand why they're co-located. That's a whole area to discuss at some other time. The anatomy is fascinating and challenging, and I chose the pancreas because it is surgically a very challenging organ. It's not in the abdomen. It's behind the abdomen. And it lies, as I like to say languidly, over the spinal cord, over the aorta, over major vessels. And so the dissection of that gland is complex and risky. 3 common diseases, all of which have fascinated me. Acute pancreatitis is one of the most common gastrointestinal admissions, and we're going to focus on that tonight. Chronic pancreatitis, not the same disease, incredibly painful disease. People get depressed with it, and pain is really difficult to control. And then pancreatic cancer. It's going to be the 2nd or 3rd most common cancer death as we go forward. We are making some progress, but most of my pancreatic cancer surgery was in the end palliative. And I appreciated some of the comments tonight very much. So, the cause of death over centuries has changed. When you look at the list on the left, common diseases, in the old days, death used to occur as a direct result of the primary disease. We're not much better at caring for patients now, so death is most often actually not from the primary disease at all, but from what we might call secondary disease or organ failure, which is the topic I want to talk about tonight. And really, organ failure has been called the plague of modern medicine. The better we get at treating the primary disease, patients ultimately sometimes die, and this is what they die of, organ failure. And so here's a picture from the intensive care unit or Department of Critical Care Medicine in Auckland. You've got a patient who's anonymous on that. You can see a lot of things happening around that bedside. This is what it looks like when you're in organ failure. You can see a dialysis machine, kidney failure. You can see a ventilator, respiratory failure. You can see infusion pumps here for inotropes and other things like that, cardiovascular failure. You can see blood transfusion happening, intensive monitoring. This is what it looks like in intensive care. And when a patient gets into this state, there's a 20, 30, even 40% chance of dying still. Why is that? Well, we're very, very good at organ support while the disease takes its course. But people ultimately die of organ failure because we actually don't have a treatment for the organ failure. We support the physiology, but we don't have a treatment which addresses what drives organ failure. So, apologies for those who might be a little bit squeamish. Do look away if you need to. This is a rare picture of a fresh pancreas from a patient who died who also had acute pancreatitis, and I use it a lot in my teaching. Sorry, beg your pardon. So local problems in the pancreas can, in simple terms, be described as there's an inflammatory process going on, swelling and redness and that. But there's also a process called necrosis, where part of the gland actually dies. A failure of microcirculation, the premature activation of the pancreatic enzymes, which should be digesting the food in the duodenum and small bowel, gets activated in the pancreas, and the enzymes turn against itself and start to digest the gland itself. A really fascinating process. But there's not just local problems with acute pancreatitis, we also have organ failure. And so these are the three organ systems which fail most often, and I've mentioned them already: lungs, heart, kidney. And when you look at the pattern of organ failure in patients with acute pancreatitis and the pattern of mortality, it's been a bimodal distribution. There's early deaths, which we talk about as cytokine storm. All the inflammatory cytokines, the cascades just go out of control, and this seems to drive that early organ failure. It's not the only explanation, but that's what people say. And then we have a later organ failure that might be weeks in a patient with severe acute pancreatitis. That's due to infection of the dead tissue within the pancreas. So infected pancreatic necrosis leading to organ failure. We are now much better at the treatment of infected pancreatic necrosis, and that second peak is pretty much flattened. So we're really dealing with early severe pancreatitis and organ failure in the first 1 or 2 weeks as the main problem. So the risk of organ failure and death in patients with severe acute pancreatitis is similar to what you would see with an acute coronary syndrome or a stroke. It's that serious. And when you come in the door with those diseases, there's immediate things that happen. You know, it's an emergency. Whereas if you come in with pancreatitis, we don't have anything to do like you would with a heart attack or a stroke. Okay, so in my clinical practice over 35 or 40 years with pancreatitis, there's 3 pretty barn door obvious observations which have struck me. They're not original to me. In fact, everybody could observe them if they looked. The first is that there is a stereotyped response to acute and critical illness. Now, irrespective of whether it started with meningitis or pneumonia or multi-trauma or severe hemorrhage, pancreatitis, what happens to the patient and what happens at, when you assess them at the bedside, it actually looks similar. You wouldn't know what the underlying trigger was or disease was in many, many cases. And you go from a process, as you see here, of systemic inflammatory response through to multiple organ dysfunction syndrome, and then to multi-organ failure and death. That sequence happens irrespective of the underlying disease. That's an important observation. And why is it important? Because it suggests If there's a common response, there must be a common mechanism. Secondly, and you've probably seen this in your visits to an intensive care unit, it seems that patients with acute and critical illness swell up. In fact, not in the earshot of patients, one hears the description, the Michelin Man, if you know the advertisement in the States. I mean, these patients can become incredibly edematous, and you can see that in various parts of the body and through a number of different processes, which we don't need to go into. And there are consequences of edema, and we now talk about the fluid accumulation syndrome affecting the organ function in all the systems. Gastrointestinal down the bottom there, but all the systems can be impacted by this edema. When I grew up in surgery, I was told by Professor David Carter in Edinburgh, when you're giving fluid therapy in acute pancreatitis, you just keep giving as much as you can until you start hearing creps in the lungs, which means, you know, some respiratory failure. Just load them up. They need fluid. We now know that that kills patients, and there's an optimal amount of fluid that we should give. But our patients were often quite edematous, and I'm sure that contributed to poor outcomes. The third clinical observation one might see in radiology, where a patient with acute or critical illness, acute pancreatitis, may get a distended abdomen. They may not be able to pass wind. They might have high volume of aspirates or vomiting because the bowel's just not working. And that's what we call ileus, which you see here. If you do a CT scan, you might see gas in the wall. That's gas in the wall of the bowel, which you can see histologically here as little bubbles. That can resolve. But it's indication of ischemia of the lining of the bowel, if not ischemia of the whole thickness of the bowel, which you see here. If we open up a patient with severe ischemia of the bowel, it looks like that. You flick the bowel in theatre, it doesn't respond, it doesn't contract. It's distended, a little bit smelly, and you might in fact encounter perforation of the bowel. Quite a severe problem, non-occlusive mesenteric ischemia. So we got pretty interested in the gut. And I grew up in India in the Himalayas as a child and was very aware of the caste system. And I, in my own mind, have always thought about the gut being considered a second-class citizen. And in one sense it is, because there are vital organs. The gut is not one of them. You know, for immediately required for life, you need heart and the lungs for sure. Kidneys, probably not the brain. In fact, you can live without brain function. Not very high quality of life. But what happens in acute and critical illness, especially when blood is required to vital organs, where does the blood come from? Where does that extra supply come from? It comes by vasoconstricting, contracting the vessels supplying the bowel. What does that do? Well, it causes ischemia of the bowel, but we're prepared in our body, our physiology, to sacrifice our gut for the sake of the function and perfusion of vital organs. So I mentioned non-occlusive mesenteric ischemia. Infarction means death, and we can have different diseases causing a bit of redness here. Ultimately, that duskiness and death. You can lose the whole bowel, full thickness, infarction, perforation, peritonitis, multi-organ failure. And so this process can be subclinical. That is, all that you see is a bit of distension, maybe a little bit of tenderness, and people don't seem to regard it as a serious problem. But there are definitely consequences of even mucosal ischemia of the bowel, and we'll come to that. I love this study. We did it in the mid-1990s with Professor Bonham's son, Martin, a Yugoslav who came to us as a refugee, and Frey from the Middle East, who gave 5 years of his life to our lab without asking for any money. And we did a number of, I think, important early studies. One of them was this. This is a catheter that's placed in the stomach, but it's got a balloon. Can you see the balloon with fluid in it, just saline in it? It's semi-permeable to CO2. So you can sample that saline and get a CO2, carbon dioxide measurement from that. And that gut is producing CO2. If you take a blood gas and take a bicarbonate from the blood gas, you can calculate from these two sources a pH. And we call it PHI, or intramucosal pH. There's some assumptions in there, but it will actually tell you how ischemic the gut lining is. This is the first study that showed that if you've got a PHI less than, sorry, not good at that. If you have a PHI of less than 7.25, you've got a high probability of death. So linking gut ischemia with death in pancreatitis was the first time that was done. The other thing that I think that's important to note, in our zealous attempts to treat organ failure and maintain organ function at all costs, we actually can further damage the gut. Even common things that we do, opiate analgesia, inotropes, fluids, antibiotics, enteral feeding, all those things can contribute to gut ischemia, gut injury. And you'll see why I think this is important. So, just to summarize, organ failure can cause gut injury, and gut injury, as I'll be showing you soon, can contribute to organ failure. That's a vicious cycle. And so gut injury and organ failure and gut injury. So other people obviously have been interested in the role of the gut, and various concepts or models have been developed. One of which is the gut motor concept, and many people have heard the word bacterial translocation. This means that if the gut wall is damaged, bacteria, which is in the, we have lots of bacteria in our gut, they can get out, they leak out through this damaged gut, they get into the blood supply and make people sick. The trouble is, people who've been measuring bacteria in the blood coming from the gut have not been able to prove this theory, at least in the context of multi-trauma. So there's some questions about that. Then there's the gut starter concept, which is that the gut's compromised by a lack of blood supply. How does the body respond? It sends in the troops, white cells, neutrophils, lymphocytes, monocytes, macrophages, and they are activated. They produce cytokines, and that's what drives the systemic inflammation. And then there's this gut lymph concept, which was published by Edwin Deitch in 2006. He never made any attempt to take that concept through to treatment of patients. It was all done in rats. But I can't take primacy there. But we did publish this paper independently of him and came to the same conclusion that the lymph system that drains the gut might actually be a way in which badness, to use a very medical term, badness might actually get through to the lymph, and by getting into the lymph can get into the circulation, and by getting into the circulation can actually impact organs. Just a couple of words about lymph, because not everybody is aware of lymphatics, and we've made a special study of that. We weren't there in 1670 where the groin lymphatics were demonstrated by this Dutchman. We can see lymph nodes, opalescent lymph nodes, and it's a bit of artistic license here, mind, but you can see the little lymphatics joining the lymph nodes together, almost like a pearl necklace. So when we teach in intermediate schools, when we go along, everybody knows that arteries are red, veins are blue, lymphatics are green. Well, they're not, but that's how we depict them. And the lymphatic system is depicted here from the Cleveland Clinic. And you can see that the capillaries of the lymphatic system are little like fingers that sit amongst the cells. Fluid gets into them and are passed up through capillaries, lymphatic vessels, lymphatic duct, through nodes, actually traverse through the nodes, and then actually end up in the main collecting duct, which is called the thoracic duct. And we're going to talk a little bit about the thoracic duct. Interesting about the thoracic duct is that the lymph that runs up there bypasses the liver. It doesn't go through a detoxification system or get sorted by the liver as the blood does. Lymphatics bypasses it. And it does that because lymphatics absorb fat, and you don't want a lot of fat going to the liver. At least that's my simple explanation. I'm only a surgeon. So the thoracic duct enters into the circulation, and as we'll see in a minute, that's unfiltered, not detoxified badness that's getting into the circulation. The roles of the lymph in normal health is that we absorb fat by that means. That's how we get our fat when we eat fat. It returns fluid from around the cells, what's called the interstitial space. If you didn't have the lymphatics, you would just blow up and pop. I mean, this is the way that we return fluid to the system. And you need fluid to get out of the system to bathe the cells, to give them the nutrients, to take away the poisons from the cell. So that process of exchange is really important. But if you just left the fluid there and didn't have a lymphatic system, then you wouldn't live. It's vital to life. And then, of course, immune cells traverse the lymphatic system, are really important for lymph surveillance all over the body. So just coming back now to the gut lymph model, we tried to summarize it in this paper. Let me take you through it just so we're very clear about that, because so much hinges on this in the rest of the talk. Steal my thunder. Okay, guys, here we are. Number one, those are the lymphatics in the gut. So if you've got gut injury from all those reasons we talked about, badness gets into the lymphatic system, correct? In the lymphatic system, it goes up to a little receptacle, if you like, called the cisterna chyli. And then the cisterna chyli becomes the thoracic duct, number 3, bypassing the liver, going all the way up and entering into the subclavian or the internal jugular vein on the left, not the right, just on the left. And where does it go from there? It's directly exposed to the heart, the lungs, the kidneys. Those are the organs which fail most often, which kill people most, and yet we haven't really connected the dots until very recently. And when I teach about it, I kind of talk about it. Really, it's like unfiltered sewer just getting dumped into the circulation. That's what it's like. Okay, that concept is based on some experimental work. I'm going to make this as painless as possible for you, but I do think you need to see a little bit of science, a little bit more modern than that. So the first thing is, can we show that the composition of lymph coming out of the gut in these circumstances is indeed changed? The composition, are things different with that lymph? Because we're making a claim that it might actually drive organ failure. And so we've done that, and we've looked at multiple ways of looking at compositional change, and I'm not going to go through all that other than to say that talk about proteomics. Proteomics is looking at what proteins are in the lymph and what changes in proteins occur with acute pancreatitis. So what we have here is all of the protein groups. You'll see there's pancreatic enzymes, just 2%, and protease inhibitors. The largest protein group is the group which is protecting the body against the action of proteases, which damage protein. And of course, the enzymes from the pancreas are about breaking down protein. So pancreatic enzymes only represent 2%, but the protease inhibitors, 16%. It's almost like there's protection there waiting for something to happen. So that's in normal. What about the proteome from lymph in acute pancreatitis? Well, it really surprised us. Of all the different proteins that are in lymph, only 8 proteins we were able to demonstrate increased their levels in acute pancreatitis. That's only 3% of the proteins. And when you actually look at them, 7 of the 8 proteins which increase in lymph are actually pancreatic-derived enzymes. This is lymph coming out of the gut, not lymph coming from the pancreas. And the one I wanted to draw your attention to the most is the one up here, pancreatic lipase, because that's going to come into the story in just a minute. So pancreatic lipase is 38 times increased in value, in concentration in lymph in acute pancreatitis. And there's no increase in the anti-protease protection. So the second experiment was to say that if this lymph coming out of the gut is nasty, what happens if we drop it onto some cells? Will they like it? Will they not? And so the cells we chose were a cell culture of cells that are derived from the lining of vessels, endothelial cells, hem-sac cells there. And what we've got here is a little graph, not too heavy, right? This is LDH, which is a measure of cell death. And what we've got here is controlled lymph, not very much death when you drop normal lymph. If you drop normal lymph and an anti-protease drug, not much death. If you have acute pancreatitis lymph on those cells, heaps of death. And then if you combined acute pancreatitis lymph with an anti-protease, back to very little death. So it tells us that there's, in acute pancreatitis, we've got something toxic to the lining of vessels. That's just one of many studies, but as an example of a compositional study that actually also confirms toxicity. I've already talked to you about the fact that in pancreatitis we get necrosis. Gee whiz, you'd think I'd have learnt by now. Necrosis. And so one of the questions we asked was, is the lymph coming from the gut contributing to the failure of the circulation of the pancreas, which is responsible for the necrosis? You with me? So we had a nice setup where we had 2 models. Grateful to the rats for their help here. This is a little cuff that we put on the artery which supplies the gut, and we can blow up the cuff and make it ischemic. And the second model is we can put a little tube through the duodenum into the pancreatic duct and infuse terracolate, and that can give us a pretty predictable severe pancreatitis. And if we use a low concentration, a mild pancreatitis. Okay, so what we wanted to do was to take lymph, take lymph, it's far too complicated for me, take lymph from a rat that's been subjected to gut ischemia, not pancreatitis, just gut ischemia. So we've got lymph coming out of gut ischemia, and we then infuse it into another rat that's got mild pancreatitis. And we've got the abdomen open of that second rat so that we can actually look at a mild pancreatitis pancreas on a platform, warmed, heated, irrigated, and actually be able to bring a microscope down onto the organ and actually look at the circulation as we expose it to lymph from that intestinal ischemia. Is that okay? Okay, so maybe a bit too complicated, but here's what the capillaries, the blood supply, the little dots that are whizzing around are red cells actually, and so that shows you normal capillary blood flow, and then just what happens in acute pancreatitis starts to get slowed down, doesn't it? It doesn't whiz around quite so much, and so there's some impairment of flow there. And then when you've got acute pancreatitis plus lymph infused at the right concentration, what happens? Circulation pretty much shuts down. So that's a pretty potent something in that lymph, causing such a significant reduction in microcirculation. So acute pancreatitis, we know, can cause intestinal ischemia. Intestinal ischemia can actually impair pancreatic microcirculation and can make acute pancreatitis worse, as we demonstrated in that experiment with some other slides. So, the fourth experiment. So, this is gut lymph from acute pancreatitis causes heart failure. And this is it's always been a mystery to intensive care doctors, as far as I know, and I'm not one. What is the thing that depresses cardiac function? They've never actually found that. What's the cardiodepressant they talk about? Not the same kind of depression. Here we've got an acute pancreatitis model, the same one. We've taken acute gut lymph out of this rat's thoracic duct and infused it into a little rat heart, which is perfused and paced, and they actually use that for diabetic cardiomyopathy studies. So we're able to adapt it to this. And as a result of that, here's another graph. This is called the Starling curve, which is how we learn our cardiac physiology. But if you increase the load on the heart upstream, what the heart does is responds to that and actually puts more blood out. Makes sense. Put more in, get more out. If the heart's not working very well, you won't get so much out. And that's actually what's shown here, is that with look at this one here, the black one. There's a 20% reduction in cardiac output if you've got acute pancreatitis lymph infusing the heart at a really low concentration, which we think is the kind of concentration it would have normally. So this was almost immediate 20% reduction in cardiac output, cardiac failure as a result of lymph being infused into the heart. And to cut this one short, if you were to ligate the thoracic duct so lymph can't get through to the circulation in acute pancreatitis, you can completely abrogate the heart failure. It just doesn't happen. So you can see that this is the cardiac failure that then returns to normal if you ligate the thoracic duct. So again, thoracic duct is a highway that is conducting a whole lot of badness from the gut to the circulation, and we've almost completely ignored it. So this is the last section. I'm probably ahead of schedule, am I? You're doing well. Yeah, okay. But we can take lots of questions. So that's the concept, that we've got gut lymph model says that damaged or injured gut in acute and critical illness produces badness, which is conducted by the lymph system to the circulation, and that causes organ dysfunction and then potentially failure. So in thinking about how to design translational strategies or treatment strategies, there's all sorts of things we can talk about. And I'm only going to talk about 2 of the several that we're working on. And I'm obviously quite excited about this. So finally, after, I think it was a TED talk in 2009, I first broached this idea. And now we're, many years later, finally getting translational strategies in place. So the first one is not original. It says, well, actually, if we put a tube into the thoracic duct and bypassed the circulation and allowed the lymph to drip into a bucket by the bed, if we did that early enough, would we actually be able to avoid some of the downstream effects of that bad lymph in the circulation on organ systems? So we actually did two reviews of the literature, one in English and one in Russian and Ukraine. There was a retired Russian professor in the University of Auckland who freely gave his time to translate 113 Russian papers, which we're really grateful for. Here's a really old picture from a surgical textbook showing that this is not something that's new. You look here, there's a tube going into the thoracic duct here, and here's a bottle by the bed with dripping lymph. You can see the thoracic duct here entering the system, and they've got a tube sitting in there. So when we actually looked at the publications, one of the things that strikes you immediately is there's a flurry of activity in the 50s, 60s, 70s, into the 80s. The orange is the first paper, which was the English literature. The blue is the Russian and Ukraine literature. And you can see that the Russians and the Ukrainians did a few more studies more recently, but it completely died in the English literature. Nobody did it. Why? Well, one of the reasons for doing it was to actually cause immunosuppression in the early days before cyclosporin. And so they would actually drain lymph for up to 4 weeks to try and immunosuppress a patient before they did an organ transplantation. Cyclosporin came along, no longer needed. However, it was an open operation, and I think cosmetic reasons are very real. Nobody wants to have a cut in the neck like that. It's an invasive procedure. It needs a general anesthetic. But when you pull the tube out, not like arteries or veins, it doesn't clot. And so you end up getting a lot of lymph leakage, which we call a chyle leak or lymph leak. And so that's a problem. Another problem really was when we looked at the quality of the studies. They're all pretty small. They're all underpowered. The statistics were pretty crappy. And you'd have to say that when you looked at the results, the vast majority of them showed a positive result. And that's what surprised us, that nobody really had taken these early preliminary findings and actually put together a proper randomized controlled trial and demonstrated the benefit and actually introduced it into medicine. So I think the Forgotten Highway, this reference in case those hadn't guessed what we're talking about, I think the lymphatic is that, thoracic duct is that. There are good reasons to why we would want to access thoracic duct lymph. For us, it's gold, really hard to come by. The first one is therapeutic external drainage, which we'll talk about in just a second. But there are other reasons why. We could study the compositional changes that occur in lymph over the course of a disease. We can't do that at the moment. We could study the toxicity better than what we've done to date and do it in vivo by actually taking lymph from patients instead of from rats and actually demonstrating, confirming our rat findings. Really important is to identify potential drug targets. What is the toxicity factor? We've got a number of targets, but there are others which we haven't found yet. Let's find them and let's use combination therapy to take them out before they get to the circulation. We could actually design gut lymph targeted treatments And we could actually measure the bioactivity in gut lymph if we could get a tube into the thoracic duct. So it's a precious fluid that we seek to study. So maybe a little bit brazenly, all done ethically and with the right approvals, we decided we need lymph. We need to study lymph. And as it happens, excuse the picture for those who are squeamish, this is a thoracotomy and opening the chest. I was doing an esophagectomy here. The lung is compressed above, ribs and intercostal veins are at the bottom, and in the middle is the aorta. This is the aorta. And running along the aorta is a thoracic duct with a little clip on it and a little cannula in it. So what we did with permission was, because we ligate or tie off the thoracic duct in patients anyway for cancer surgery, we thought we'd cannulate it for 7 days and then embolize it, meaning that the radiologist would go down the tube and just put a series of coils in there to stop so it doesn't leak. Unfortunately, 2 of my patients of the 4 did leak. And this was really hard to deal with. And we definitely discontinued the study. Actually, both of the reasons were avoidable. There's a lack of vigilance on the part of my research fellow for one of them. And the other was that the embolization step was delegated to a junior in the radiology department who put 3 coils instead of the 8 that's standard. So, you know, it was a pity. We did get some lymph, and we've actually published on it, and we've thanked the patients, especially the ones who had lymph leaks. They've come back to clinic. They're good with it, but it was a bit of a harrowing time, to be frank. And then we met a Russian, Professor Max Itkin. He works at the University of Pennsylvania, UPenn, in Philadelphia. And he's not cutting the neck. He's getting into the thoracic duct with a tube without any incisions. And he's doing it consistently. I had a look at his data set of 962 cases, 2 episodes of minor SIRS response, maybe infection, but nobody had any major problems. I'm going to just show you his technique, which I think is a really major advance. It's not surgical, it's radiological. What you have here is a groin, and this is groin nodes. So what he does under ultrasound guidance is put a little needle into a groin node. You can probably feel your own, they're usually quite prominent, and then inject lepiodol, a contrast agent. And it's quite beautiful sitting there with the X-ray machine going to see the lymphatics go from the groin nodes around the edge of the pelvis, almost like a flower bloom, and then coalescing into the cisterna chyli, that receptacle at the lower end of the thoracic duct. And then the second step, which you see there, having opacified the thoracic duct, this is the scary bit for us when it started. I meant to bring it. I've got a needle which is literally this long with a little curve on the end of it, and he punctures the abdomen. I said, "What are you going through?" He says, "Well, I don't know, but it's 25 gauge and it doesn't seem to cause a problem." So he was very careful, and he just popped it in and then managed to cannulate the cisterna chyli, which is outlined with contrast, and then passes a wire up. I think I have a video that might work for you. Yes. Can you see a lasso there? And there's a wire. That wire is coming up the thoracic duct and then around there and into the vein. And then what happens here is he grabs the end of that wire, which has come up from below, and he pulls it out to the arm. So you've got a wire coming out the arm and a wire coming out the abdomen, same wire. And then over the wire on the arm, he can reliably pass a catheter into the thoracic duct. Wow. No incisions, no general anesthetic. He's got reliable access to the thoracic duct. And all of those reasons why we want lymph, we can now obtain by this method. Really a significant advance. And we took a radiologist from Auckland to UPenn, and they're now starting to do it here, which is great. So when you think about external drainage of thoracic duct, I think about, let's get rid of that toxicity, but then we could also get rid of excess fluid. Because if we can actually allow the thoracic duct to drain all of that puffiness that patients are having, we might be able to unload the patient of some of the excess fluid. The only study that we could find in English literature that was done outside of Russia and Ukraine in acute pancreatitis patients was this one paper in 1989, which demonstrated improvement in respiratory function, circulatory function, and survival in patients who had external drainage of thoracic duct lymph in severe acute pancreatitis. I think it's a landmark study. Was never followed up. A proper full-size study hasn't followed it. They just simply said this could be a useful adjunct to the treatment of life-threatening complications in early phase acute pancreatitis. Needs to be repeated now that we've got a minimally invasive approach to the thoracic duct. So where are we at to? Well, number one is we set up a sepsis study in UPenn, because Max Itkin's there, he can do this for us, in an intensive care unit in UPenn, screened over 60 patients during COVID. Nobody wanted to participate. So this is the reality sometimes. You set up a jolly good study and nobody wants to be part of it. So that was stopped, but I think for good external reasons. We've been back there and said, well, would you consider doing one in acute mesenteric ischemia? We talked about gut ischemia. In these patients, sometimes you have to revascularize, etc. So we've actually got a study with external drainage in patients having surgery for acute mesenteric ischemia. Those patients get sick afterwards. If we can stop the sickness, stop the organ failure, that will be an amazing study. Hopefully we'll see positive results. The other one, which is quite interesting, is that they have 23 cardiologists at UPenn, all dedicated to intractable congestive heart failure, meaning these are patients who are diuretic resistant. You know, they come in with heart failure and you want to get that fluid off their lungs, decongest them, but the kidneys won't work. In the 1960s, somebody did external drainage for patients with severe congestive heart failure, taking off up to 8 liters a day out the thoracic duct. Patients shrunk, patients walked out. That's amazing. And so that group have, because they're in the same hospital as Max Itkin, I've brought them together and say, look, you've got plenty of patients. Some of them are going to die. Well, most of the intractable ones will die without treatment. And maybe this is just a bridge to cardiac transplant. Get them home, get their nutrition better, get them in better shape, and then come forward for transplantation. So I think that's useful. And in Chengdu, China, we have a group of radiologists who are going to help do an external drainage in acute pancreatitis, which is what I'm really excited to do. I'm going up there next month to try and get that started. Okay, that's the first strategy, which is external drainage of thoracic duct lymph. Crude concept, just put it in a bucket. That's all we're doing. This one is much more sophisticated and beyond me, really. We're working with Monash Institute of Pharmaceutical Sciences, who are ranked QS #1 in the world for drug design and delivery, and they've been fantastic to work with. I'm not going to bore you with too much detail, but I want to come back to lipase. Remember that enzyme that went up a lot in the lymph? And so this here, over here, in yellow, which you can hardly read, says orlistat lipase inhibitor. Orlistat has been on the market for years as a drug to treat obesity. You may have heard of it. How does it work? Well, in the diet, if you have fat, lipase will come from the pancreas and break it down. If you stop the lipase from working, the fat stays in the bowel and you get bloated, uncomfortable, don't want to eat, and you pass fatty stool. That's how it works. And it doesn't get into the circulation, it just stays in the gut. So the concept here is if we could use orlistat as an anti-lipase, and instead of it working to lose weight in the gut, we actually target it to the lymphatic system. Lipase working in the lymphatic system, we could stop lipase. Well, why would we want to stop lipase? Lipase produces, in its breakdown products, fatty acids, non-esterified fatty acids, which have been shown to cause respiratory failure and cardiac failure. So if we could actually have anti-lipase treatment targeted the lymph before lipase gets into the circulation, that's a target worth pursuing, which is what we've done. And so in order to do that, we've had to have these self-nano-emulsifying drug delivery systems, SNEDs, and you can see what goes into a SNED, the drug itself, a co-solvent, surfactant, and oil and lipid. And these form themselves into small bubbles, if you like. And as a result of that, instead of orlistat staying in the gut, what does it do? It gets into the lymphatics. And we've demonstrated that. Well, here it is. We tried to combine it with a number of different things. The one that seemed to work the best overall was actually oleic acid, a long-chain lipid. And we've demonstrated that it gets into lymph in high concentrations, which is here. And then here, we can actually show that orlistat in this situation also gets through to the plasma. And so here we've got a drug that gets delivered to where we want to get it to, but it's joined up with oleic acid. Well, the good thing is the target that we're going for is lipase, and lipase cleaves, this is pretty cool, lipase cleaves the tail, leaving lipase active, anti-lipase, orlistat, I beg your pardon. It cleaves the tail, leaves orlistat available to actually then counter the lipase, which is freed it up. And so it works, and I'll show you. So we set up a study where, a rat study in this case, of acute pancreatitis, said, well, if we give orlistat targeted to lymph, can we make a difference to the outcome of acute pancreatitis? What you see here, without going through too much detail, is you've got lymph treatment. If you give orlistat with a pancreatitis, you have toxicity to the cells. There's two different cell lines. This one you came across before. You can see that with the pink is with acute pancreatitis, and you have low viability. That is, not a lot of cells survive. If you give orlistat with acute pancreatitis in the way that we've just been talking about, the cells survive much, much better. So that's an indication that you can reverse the toxicity to cells with this approach. Lots and lots of pictures here. It makes a jot of difference to cytokines. This has nothing to do with cytokines. All of those on the back, you can see that the blue columns are pretty similar to the pink columns. There's no real difference. And then the next part of this was plasma lipase activity, that is lipase that's come up the thoracic duct into the circulation, and free fatty acid levels. And what you can see is that if you give orlistat with acute pancreatitis, lipase levels in the blood goes down, good sign. And what you see is that the toxic free fatty acids dramatically decrease. And so that if it's true that fatty acids drive organ failure, this is going to be helpful. Well, we went further than that, and we looked at actually what happens to blood pressure. Because of the acute pancreatitis, the blood pressure sagged, and in fact, the orlistat restored the blood pressure. You can see that there, restored blood pressure. Then we looked at markers of heart function. There's a whole lot here, CK, MB, troponin, fatty acid binding protein, etc. And what you can see in most of these is that acute pancreatitis levels are high, and we actually improve the levels. All of these different markers of cardiac function improve with a treatment of anti-lipase therapy to gut lymph. Amazing. We went further than that, and so we wanted to look at other organ systems. Here you've got kidney markers, creatinine and urea. Here you've got liver markers. The same picture all the way along. Orlistat is beneficial in every single case. And this is at 3.5 hours after the induction of pancreatitis. So, coming to the end. We're very excited about that animal study, and I don't think I've shown it here, but we are now moving ahead with that drug formulation, now patented. Actually, we've got it here. We're looking for a partner to help us. We're planning the first human randomized control trial in Chengdu. I'm going to be dealing with that when I go up there as well next month. IP secured. Commercial partners being sought to allow us to proceed with that. But this is the first instance of a lymph-targeted drug impacting systemic inflammation and end organ function. And the exciting thing is that the orlistat is already FDA approved. The excipient, which is all the rest of the stuff, is also FDA approved for a different indication, mind you. But we're a long way towards getting FDA approval. We don't need it for a research trial, but we're underway with that. So for the first time, we may well have a treatment that's effective. So in conclusion, we've talked about organ failure being the most common cause of death from acute pancreatitis and most acute and critical illness. No specific treatment for organ failure, really good at organ support. The role of lymph has largely been forgotten. Gut lymph model is a new paradigm which is translating now into two different research or translational therapeutic strategies for us, external drainage and gut lymph targeted drugs. And we've got clinical studies in the US and China underway. I can't not acknowledge AMRF here because this support, I cut out the amount of money, but it was $159,000. Really timely support for us in gut lymph targeted treatment, severe acute pancreatitis. Not the only funder, but what AMRF has done for me over the years is actually evened out the lumpiness of funding. We might get a project grant from HSC or a program grant, but they end, and you often have these valleys, doom in between major grants. And AMRF has kept us alive on more than one occasion, almost like organ support. It's been amazing. So I'm really, really grateful to AMRF for that. There's lots and lots and lots of people who've been involved in these studies and others. And you can see the Monash University figuring very largely there. So thank you very much.
And John, that is for sure. Well done. Yeah, absolutely. So look, I think we'll do 5 minutes for questions because I know that people are probably wanting to go and, yeah, understand if you don't have any questions at the moment, but we've got a question.
I've got two questions. Does a diverse and healthy gut microbiota have a protective effect for this inflammatory response? And the second question is that drug therapies which are used for localized lymphatic tumors, do they have a benefit in this lymphatic inflammatory pathway?
I don't know the answer to the second one, but the target there would be the vessels. And what we're wanting to is improve lymphatic function, because you want to take out the lymphatics as a conduit for metastases, right? So if anything, you don't want good lymphatic function around a tumor, but you do want it for the other reasons of getting rid of badness. But so no, I don't know whether that would work or not. I'll give some thought to that. The first one was microbiome. Yeah, there's a huge amount of work going on all around the world about this. The sad thing in acute pancreatitis was that there was a publication, the Propatria trial in the Lancet, probably 10 years ago now, where they had identified several probiotics that they thought were beneficial. Randomized control trial, beautifully done by the Dutch multi-center, 20 centers, and there were 8 deaths, and they were from gut ischemia. My explanation for that is that they were too aggressive with ventral feeding, putting a huge metabolic demand on the gut, irrespective of the probiotics, and got gut ischemia from that. We now don't do it that way anymore. Is there a role? Definitely. Do we know which parts of the complex microbiome are beneficial? Starting to understand that. How we might use that therapeutically, not established yet, but I'm sure it's going to be an important component of treatment in the future. Just not there yet. It's complex.
One other quick question. We might wrap it up because I know. Sorry. Yeah. No.
Did I go over time?
You did. You did really well. You did really well.
Sorry.
Yeah. No. I mean, that's. John just managed to span about 30 to 40 years of research and translational research, so into 45 minutes, so well done. So look, I would just like to invite all of our speakers up tonight because we do have a little presentation just to say thank you for coming and for the fascinating talks. Rosemary, thank you so much. John, thank you. Great presentation. Thank you. So another round of applause, please. Thank you.
And I know you'll all be wanting to get home to your beds, but if you do think of any questions that you've had for any three of our presenters, we can, if you send them to us at the email addresses that you have, we can gladly pass them on to our fantastic presenters here tonight and answer those questions for you. So thank you very much for coming, and hope you've enjoyed the evening. I've found it amazingly interesting, so thank you again to our presenters. Good night. Oh. James gonna do. Oh, thank you. That was yeah. I can.